Professor Reed. It's our honor to have you today to be here to do the interview. So could you introduce yourself to our readers?
Sure. My name's Donald Reed. I teach for Indiana University and the University of Cincinnati and practice in Fort Wayne, Indiana, which is about 3 hours by automobile from Chicago.
So what brought you into the field of surgery?
My first exposure actually was as a medical student. I didn't even know any surgeons, but as a medical student, I loved the ability to surgically intervene in an illness and correct it rapidly. And that kept me interested enough to do a residency and then a fellowship and then another fellowship.
I know you are one of the members in the ACS committee, and you have been attending many of the lectures. So what impressed you the most during the meeting?
During this Congress, what impresses me the most is the number of international attendees.
Okay.
The meeting has always been an excellent source of physician and surgeon interaction, and having the opportunity to have intercourse with colleagues from around the world. But at this meeting, and I've been to many of these meetings the last 30 years, I think the first one I attended was in San Francisco in 1984.
Wow.
At this meeting, I believe I see more international attendees than I've ever noticed before.
So I know you are specialized in endoscopy. Tell us some the recent developments in endoscopy.
What kind of environment, I'm sorry?
I know you are specialized in
Correct.
endoscopy.
Yes.
And you have been in this field for many years.
Correct.
So what developments do you witness in recent years?
I did my original fellowship where I studied endoscopy and HPV surgery at the University of Louisville in 1988 and 99. So in the 16 years since that I've been practicing that, I joined the American Hepatobiliary Association and the International Hepatobiliary Association, where I've had the privilege of presenting before. The biggest trend I've noticed over that period of time is the increasing number of disease disorders that are amenable or treatable with endoscopic means. And that, I think, evolution, if I might use that word, has been a twofold process. On the one hand, there have been tremendous technical advances in the industry in terms of the endoscopes themselves and the endoscopic equipment that is used with that. And second is that I think endoscopists, whether they're surgical or gastroenterologists, have begun to, well, we have a term in English, it's called think outside the box.
Yeah.
Where you try to use a particular technology or treatment paradigm for something that wasn't used for traditionally. And an example might be, this is an old example, but endoscopic treatment of esophageal varices. For instance, around the world, and I know China in particular, cirrhosis is a problem, portal hypertension is a problem, lots of surgery, wonderful surgical techniques have been developed for that. But for variceal bleeding, most of the advance has been endoscopic treatment with ligation of varices. And when I was in training, I don't think that even existed. Nowadays, we take that for granted. But to operatively intervene on portal hypertension with esophageal varices causing an upper GI bleed, the mortality is horrendous. So to have an endoscopic treatment option for those patients is an incredible advance. Now, you can get into debates about, well, maybe it's short term and maybe other treatments are needed, or treating the cirrhosis with a liver transplant and getting rid of the portal hypertension might be better. But for the average patient presenting with esophageal variceal bleeding, the endoscopic treatment, I think, was a paradigm leap in healthcare, basically around the entire world.
So what are the difficulties now in endoscopy?
I think the difficulties now are, among others, it's getting well-designed studies that are able to distinguish the multiple treatment options you have, not only comparing endoscopic treatments, but perhaps now laparoscopic or minimally invasive surgical techniques that might offer some advantages. And most papers I notice in the literature today, our journal notwithstanding, is that they are endoscopic treatment or medical treatment versus another endoscopic treatment, rather than endoscopy versus surgery, for instance, that kind of thing. You may have heard of the field of NOTES surgery, natural orifice, transoral endoscopic surgery, where, for instance, you might go through the mouth or through the anus and remove an organ, like an appendix or a gallbladder. I think that is, in my opinion, sort of the cutting edge of minimally invasive surgery.
Right.
But the problem is it's going to require very ethical and thoughtful study design to make sure that these are not just physicians or surgeons who are motivated for one reason or another to promote a particular application or technique, but rather do an even-handed, balanced approach to both to see whether or not it's an advantage. Most studies today, I notice, show a lot of approaches that are favored apparently by the author, and I think lack in their study design comparing it with what else is available.
So, in your opinion, what are the future development for endoscopy?
Future developments for endoscopy, I think, are going to be basically size. For instance, now we're using a flexible fiber optic scope that I think is 3 millimeters to go through the ERCP up into the bile duct, and then it has a 2 millimeter working channel. With a biopsy forceps, I can literally look at what I suspect is a tumor and get a direct biopsy. I think that is a real technological advance. In my entire career, which is almost 29 years, that's never been possible.
Wow.
Second, not practically anyway, second is endoscopic ultrasound. Ultrasound is used much more elsewhere in the world, I think, than it is in the United States. But I have a colleague who does endoscopic ultrasound, and I think we're only seeing basically the tip of the iceberg in terms of what's available for that. Mostly now it's diagnostics. I think one day in the not too distant future there will be treatment options offered with endoscopic ultrasound. So you would, for instance, put down an endoscope, use an ultrasound to locate a tumor, and then maybe have another device, parallel or an overtube or something, that might then be able to go in and remove that tumor.
Wow. So what are you and your team doing recently?
Well, recently we're doing old-fashioned surgery. We don't do much cutting edge.
You do any studies or investigations?
No, I have a new colleague, and we have talked about some new study designs, but right now it's too preliminary. They're not ready for prime time.
Okay. So final question. What do you love about surgery?
What do I love about surgery?
Yeah.
On an easy day or on a hard day?
Both. You can say both.
On an easy day, I like the rewards of taking care of a particular problem in a straightforward fashion and being allowing that patient to move forward in their life. I find that part rewarding. On a difficult day, it's hard to say what I appreciate. I appreciate the end of the day, whenever it is. That's mainly what I appreciate.
That's very honest.
Yes,
Thank you very much.
You're welcome.
Thank you.
Pleasure to
It's
talk to you.
Really good English. Thank you.